I'm going to try to tailor this as best as I can for all those attending, which is sort of a wide variety of probably some of people who have quite strong stomachs and others that perhaps don't like the sight of blood. So the slides are not that bad really as far as I'm concerned, but just so you know, I'll try to give you a little bit of a warning. I'm going to try to give you some idea as to how this all got started with Dr. Guyron and Dr. Jennifer Kriegler and Dr. Reed in Cleveland. Dr. Guyron worked with Dr. Reed, who's now at the, where is she? She's at the Cleveland Clinic. She's at the Headache Center there? Okay. And Dr. Reed, how long have you been with Bauman now? 2003, and this sort of all Dr. Guyron. When I was in training for plastic surgery, he was scratching his head and raising his eyebrows about what was happening in terms of asking patients that he'd operated on about their headaches, and they're like, oh yeah, they're gone, and it got him curious enough, and he's quite a curious guy with one of these photographic type memories and pretty unlimited resources, I think. So he took a whole year off of his quite prolific cosmetic practice just to study migraines, and I think it's one of those things where he's kind of done everything else, and he's maybe looking for a legacy, but it's actually it's led him right into chairmanship of the residency program there at University Hospitals in Cleveland, where he's been granted a department in plastic surgery, and there aren't that many in the country that are actually true departments. And since he's taken over that department, they've hired the best ENT doc there. Their number of attendings has gone from like 3 to 10, which is quite a large department, just in a year and a half's time. And that program, I think, is destined to be probably top 2 or 3 programs in the country, if it's not really there already. I think he's been quite a draw. He's quite a name in the field of plastic and reconstructive surgery. His original origins were in craniofacial surgery at the Cleveland Clinic, and did a lot of cleft lip and palate, transitioned into private practice, and was there, and a prolific publisher because he could afford to hire people to take pictures and have a movie camera in there and everything. And then now he's back into the academic world. So just to give you some perspective, migraine disease is more common than asthma and diabetes combined. I was really surprised about that when I saw that. But it's an incredibly common disease. It's a $16 billion pharmaceutical industry to take care of that many people. It affects, and Debbie's already touched on this, it affects productivity at school, at work, as well as at home. There's an amazing cost to society. There's over 28 million people, 1 in 8 Americans. It causes a loss of $10 to $15 billion of annual productivity loss a year that we then spend on the medications. So, but basically this many hours of isolation and, let's see if I can use this pointer. No go. Many hours of isolation, I think, brings on the depression and the anxiety, and I think those with some depression and anxiety, like Deb said, are more likely to get migraine. So it's a sort of vicious cycle, and you never know, whether certain personality traits were there long before the migraines, or is it a result? And then, after 20 years of disease, it probably doesn't make much of a difference, because I think that some of those things become, ingrained and take a long time to go away. Common symptoms. I mean, everybody here, I think, is everybody pretty good on these sorts of things. This is interesting. This is really what determines what someone calls a migraine. And we use this term migraine all the time. And I really think that there's a big gray area between stress headache and migraine headache and cluster headache. And I don't buy the fact that there's an absolute distinct pathophysiology of each of those diseases, because when you talk to neurologists, and correct me if I'm wrong, Debbie, but when you talk to neurologists about how you treat, this type of a migraine headache versus this type of a migraine headache, and usually it's a trial and error approach, and you try medication. Generally, they advise you to take the highest dose, the earliest possible, to get your best response. And if that doesn't work, you go on to something else. Cluster headaches, there are some other treatments for cluster headaches. headaches, but a lot of them end up on similar medications anyway to migraines. Is that your experience as well, Debbie?
You're right. The diagnosis will help you select out of a list a little bit more accurately, but it ends up being trial and error, or
right,
like your patient said, feeling like a guinea pig after a while.
Right. The criteria is very loose. Any two of these, unilateral throbbing worsening by movement or moderate or severe, and then any one of these, nausea, vomiting, or photophobia and phonophobia. I mean, I haven't had a kind of a bad headache when I really wanted to hear loud noises, you know, or wanted to see bright lights. So that sort of takes care of that. Anybody with a headache has that, I think. And then most in my headaches that I've had, just routine headaches, I'm sure they've been throbbing, and getting up and running wouldn't be a good thing. So am I having a migraine? You know, but that's the criteria that they're using to determine whether someone has a migraine, which determines whether, you know, which of these medications to load the patient up with. So when I first started doing this, I was going to try doing it surgically, and then the more I got into studying how migraine disease was being treated and how it was defined and everything else, I was just astounded to see that it was really kind of all this classifications and, you know, menstrual migraine versus, you know, all of the other different types of migraines, and it just didn't seem very applicable to really to treatment. There was so much literature on the description of the different types of headache, and not so much on what worked better. And that doesn't really compute with the surgeon. Someone that does surgery, they want to fix it, you know. And if this fixes this cluster headache and this also fixes a migraine headache, then who cares whether, you know, whether it was this type or that type? It's just, you want to try to make it better. So a couple of myths and misunderstandings: sinus headaches or migraines. Someone has, you know, the myth is migraine pain is unilateral, temporal, and throbbing, but 40% of migraine patients have bilateral pain. So, I mean, saying, oh, it's unilateral or it's a bilateral, it must not be a migraine, is sort of a false notion. And 50% of the time, the pain is not pulsating. You know, I have people describe it as, you know, a spike through my eye coming out the back of my head. If you could just put an arrow right from here, it would come out here. And, you know, it's all these descriptions, they're not always pulsating. And, of course, the pain can be in a number of different locations. Also, nasal and ocular symptoms can accompany the migraine attacks, and usually this is that autonomic reflex from the trigeminal nucleus that Debbie was speaking of. So 45% get these, and usually, you know, things that you might think are sinusy, you know, and it might lead someone to believe that you have a sinus headache. Accompany almost half of all migraine headaches, and I would say over half, I'm guessing, of my patients, I haven't looked into that specifically, but over half of them, it seems like to me, they come into the office and they've got one red eye and it's running, or they're, you know, holding a hanky up to their nose because their nose is running, you know. So it's I see it really commonly. And, you know, most people would say, oh, you have a sinus headache, and put them on Claritin. And interestingly, of patients with sinus headache, 96% of patients, this is one study by Katie, showed that 96% of these people that have been diagnosed with sinus headache met the criteria for migraines. So, now that you know the criteria and how vague they are, it makes perfect sense that that be the case. The other thing, tension headache. Oh, I don't have migraine headaches. I have a tension headache. I just, you know, I have pain in the back of my neck. It's not a migraine. Well, neck pain frequently accompanies migraines. I'd say it's about half, or a little less than half of the patients I see have pain in the back of their neck. And actually, triptans, the abortive therapy, I'll brush through that in a second, but the triptan medications, Imitrex and Zomig, those actually treat neck pain in migraineurs better than it treats the frontal and other pain that they get. So that implies a shared pathophysiology.